All right, welcome back, everybody. It is 5 o'clock my time, 6 o'clock your time. Oh, I am so happy that spring is here and it's staying lighter, longer. Because the cool thing is, when we're done after the 3 hours, I still have a little light left in my area. All right, so we are going to pick up where we left off, which was real busy into domain number one. I want to overemphasize that the tasks that AHIMA says you are supposed to be able to perform for this exam represent the floor and not the ceiling. And what I mean by that is each task, you want to make sure that you are super clear about what that task is all about. Because it's better for you to be over prepared instead of under prepared. And I'm going to say that 900 times because I really truly believe that when you're over prepared, you can fight, literally fight questions that you're like, I don't know this answer, like based on the question, but when you see the multiple choice answers, you're like, yeah, but I know that these don't go with them. All right. So let's proceed into task number 6, which is present on admission indicators. Throughout tonight, I'm going to have, I guess I'm going to call them some mini field trips where I'm going to go through different websites. A lot of these websites I've given you guys access to, but I don't know if you've read them yet. And what I'm hoping tonight is that you're like, whoa, I need to really get into this website. So I am going to start now. All right. So by now, you should have read the POA guidelines and you know that POA is present at the time that the order for inpatient admission occurs. And in the guidelines, it talks about the fact that conditions that develop during an outpatient encounter, including emergency department, observation, outpatient surgery, are considered to be POA. And the guidelines also talk about the fact that POA is only for inpatient. It goes on the principal diagnoses. It goes on the secondary diagnoses. And now that I'm thinking about it, um, yeah, it includes external cause codes as well. So, yeah, definitely look at that list. Um, I guess I answered my own question by saying that when we first got POA, which was, let me think backwards. So the Deficit Reduction Act was 2000. It was the president was Bush, but it was the second Bush, the son. And we got POA, MS-DRG, all of this at the same time, hospital acquired conditions. So um, when it first started, it wasn't that many, and then it just grew. Also, in the guidelines, it tells us that the reporting options are like, yes, it was POA. No, it wasn't POA. U for unknown, the documentation is not sufficient. Um, W, clinically undetermined, the provider is unable to determine. And then you have the ones for exempt. And then in the guidelines, it also talks about for situations where the condition is exempt from the POA indicator, that we are to leave it blank on the claim form. We haven't talked about the claim form yet. Um, we will before our time is over. But what you really want to do is read those guidelines, right? Because in the guidelines they talk about conditions diagnosed prior to admission, um, things that were diagnosed during the admission, but clearly was, I like to say, in the patient's body, like somebody, let's say they're admitted to the hospital, they were coughing and they did diagnostic workup and found out they had lung cancer. Well, they didn't just get lung cancer from the time that they got admitted, right? It was in their body. Um, Other guidelines, what we do when the documentation is unclear, what happens when you have chronic conditions. I mean, it's just so many impending, acute and chronic conditions. It's just so many different guidelines that they give you. And external cause of injury codes are part of that. And so I'm going to just correct what I said earlier in thinking that external cause codes were exempt. They are not, unless they're on that list, because there is a guideline that says assign a yes for external cause, and then assign a no um, is a yes and a no option. But you guys read that, so we are going to look at some scenarios. And again, let me just reiterate. I know I say this every Monday and Wednesday, but I have to keep saying it. There is no way humanly possible that I can cover every topic in detail like you are learning this material for the first time. So if there is a subject that you don't know, you definitely need to um, do an inventory and make sure that you study that topic. All right, so we're going to do a couple of scenarios, and the question, the answer that you will want to say is a yes, no, yes, no, W, and U, or exempt. So here's the first scenario. A patient had surgery and was sent home. And then the patient was readmitted 3 days later with a diagnosis of post-op pneumonia. What is the POA for the post-op pneumonia? Was it present? And I know this may sound simple, but this is how my brain operates. Was it in the patient's body at the time that the admit order was signed? So, was the post-op pneumonia in the body when the patient was admitted? Yes, no, U, or W. And I will tell you for tonight's scenarios, I won't be using a timer because tonight is going to be pretty cut and dry. And so you guys are correct. Yes, it was in the body when the patient was admitted. All right, so we're going to go on to the next question. Patient is admitted with a hip fracture, and the patient, so admitted with a hip fracture. The patient has low hemoglobin. However, it dropped again after surgery, performed after admission. The physician documents acute blood loss anemia on day 2. What should the POA assignment be for acute blood loss anemia? You gotta read the scenario and understand what's happening. Admitted with a hip fracture, has low hemoglobin, but it dropped again after surgery. The surgery was performed after admission. And in day 2, the doctor says acute blood loss anemia. So I think many people would say no, it was not present on admission. Some people would say, I might want to query to see if it was present. But I personally think that no, it wasn't present on admission. And so that leads me to a statement I want to make. Um, yes, you can query for a POA indicator. All right, next patient. Obstetric patient is admitted in labor. The patient requires a C-section for a documented diagnosis of failed forceps delivery. The code reported is 066.5. What POA indicator should be reported for this condition? And I intentionally called out obstetric conditions earlier today or just a few minutes ago. So you are correct. Oh, no, no, no. Um, I mean, back up. You guys are saying no, but this is an exempt diagnosis. Remember how I showed you that list from earlier to not earlier today because we've only been on here for 16 minutes, but that diagnosis is exempt. All right. Next one. A patient is admitted with nausea and vomiting. Physician starts the patient on IV fluids for severe dehydration on admission. On day 3, the physician documents hyponatremia. What is the POA for hyponatremia? Was it present on admission? So let me make sure everybody is clear on a few things. So U is is assigned when the medical record documentation is unclear as to whether the condition was present on admission. Guidelines state you should not be routinely assigned and used in only very limited circumstances, and coders are encouraged to query the provider when the documentation is unclear. But before we say that this documentation is unclear, I want to call out something that I think I've said to you guys so many times, and that is the fact that for this CCS exam, there is an expectation that you understand what I like to call the language of medicine. And so that's medical terminology, anatomy, pharmacology, and disease process. So I think the first thing that you need to do is take a step back and make sure that you understand the conditions that are listed here. So the patient is admitted with nausea and vomiting. The physician starts the patient on IV fluids for severe dehydration on admission. And then on day 3, the physician documents hyponatremia. And if you didn't hear me say this before, I'm going to say it again. Now is the time to look up words that you don't know what they mean, because on the day of the exam, you won't have the internet at your disposal. So hyponatremia is when the concentration of sodium, Na is sodium, in your blood is low. Sodium is an electrolyte, and it helps regulate the amount of water that's in and around your cells. And hyponatremia, one or more factors ranging from an underlying medical condition to drinking too much water, can cause sodium in your body to become diluted. That reminds me, I have not had enough water today. I didn't have too much. I have not had enough. So, hyponatremia signs and symptoms may include nausea and vomiting, headache, confusion, loss of energy, coma, seizures, blah, 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 blah. So, what's your thoughts? Was this in the body when the patient was admitted? So, again, let me just be very clear. Whatever words you don't know, look them up as you go through this process, because the more you learn now, the easier it becomes. All right. A patient is admitted to undergo an inpatient total hip surgery. Following surgery, the patient develops a fever and is treated aggressively with IV antibiotics. The physician lists the secondary diagnoses of possible post-operative infection. What's the POA for the post-operative infection? Was the post-operative infection present on admission? So it was not present on admission. And one thing that I don't know if I said this to you guys before, but you are going to have a 2-day practice CCS exam. And so the questions are going to be based on these domains. So if you have just been taking notes on these things that I'm saying you should study and not studying them, um, don't get caught on the day of the exam without having done, your studying. As I've said many times, a lot of people wait until after a review class to study. The time to study is now. All right, so that's task number 6. We're going to go on to task number 7. Demonstrate knowledge of coding edits. And then they say ergo NCCI and medical necessity. I have given you guys some websites for NCCI, but I want to review those websites and a few more. I'm not sure what happened, but what what I was showing you was the Medicare inpatients edits called MCE. So in Blackboard, you have a link to them, and I would highly recommend that you just become familiar with them. Based on what I see in the edit manual, there are 20 types of edits. And so at the end of the day, we know it's a type of edit. And if they ask you a question on the exam, you need to be able to answer it. And again, I keep saying this, but I'm going to keep saying it all night. You don't want to leave anything to chance. So every task that they say that you should be able to perform, make sure you understand that topic. All right, so that was the inpatient edit system. So now let's look at the outpatient edit system. All right, so again, this particular domain this task is about the edits. So you have MCE, Medicare code edits for inpatient. You have OCE, which is the outpatient code editor for outpatient claims. Um, Embedded in OCE, you have the NCCI. So let's look at a couple of questions. And I know that most of you are coding, and so you may be involved with some edits. So I am hopeful that you will know some of these answers. All right, so let's go to the first one. So the National Correct Coding Initiative program includes blank type of edits, which can result in claim denials. And organizations use OCE software to detect inappropriate data, such as P2P, MUE, and AOC. And you may not have seen the word AOC before, and it's add-on code edit. So you know how in CPT codes um, codes you have the primary code and then you can have that add-on code. So that's the type of edit. So the answer for this question is it includes three types of edits. It includes 3 types of edits. So the answer was actually in the question. P to P, which is procedure to procedure, MUE, medically unlikely edits, and then AOC, which are add-ons. All right. The next question. OCE lists each edit code requirement which CMS uses to avoid inappropriate payment on an outpatient claim. Each edit will trigger a specific, and on the day of the exam, it's multiple choice. So terminology, and I'm not talking about like medical terminology, but just from studying, you should be familiar with different terms. And so that should help you eliminate answers that make no sense. But today, you have no multiple choice options. So I will give you what the answer is. Each edit will trigger a specific disposition. And just to kind of give you a visual, basically the software is evaluating during the claims processing payment to see if the claim is clean. So, is it incorrect code combinations? And in particular with OCE, because this is related to APC, ambulatory patient classification, the editing process also assigns the APCs. It adds or assigns what are known as payment status indicators. It's looking at if there should be any discounts on the claim, if there's a part of the code combination that should be packaged, if there's any payment adjustments. The software is doing all of this. Typically, what will happen is that organizations will have the software embedded into the systems that you're using, and so it's doing this prior to the claim being pushed out of the system. All right. Next, the purpose of NCCI procedure to procedure edits is to prevent improper payments when incorrect code combinations are reported. So let me say this again. At some point, you will have a practice, one or two actually, CCS exams, and now is the time, or it's been the time, to look at each domain, each task, look at what you know, what you don't know. This is not a coding program, it is a review class. And so you're going to have to do some additional studying. And I have to keep saying that because sometimes people think they do a review and that's all they need to do and they can go take the test. You still have to do some additional studying because everybody comes to the table with different knowledge. All right, a medically unlikely edit value. A medically unlikely edit value is assigned to a CPT/HCPCS code, indicates that the blank unit of service for a specific beneficiary, not specific, for a single single beneficiary on a single date of service. And this answer indicates that the maximum units of service. So basically, and I know that you guys are going to go and look up NCCI, and you should have learned NCCI, when you were in your respective programs from back in the day, you may not have used it in a long time. So you got to go pull out whatever notes you may have left. But basically, they're looking for situations where it is unlikely that you're going to report that service more than once on the same day. All right. And the last one, this is going to be interesting, but I think you will be able to answer this question. A 34-year-old patient underwent GI endoscopy, which included visualization of the esophagus, stomach, and the duodenum. During endoscopy, brushings collected esophageal specimens and esophageal biopsy was performed. Upon review of the CPT code descriptions for 43235 and 43239, the coder assigned only 43239 because 43235 is considered a component of the total procedure for 43239. Reporting both codes would be considered what? So what does it mean when you are reporting both codes? And only one should be assigned. And I knew that you guys would know this answer, and it is called unbundling. All right. So that's enough with task number 7. Again, do a personal inventory of what you need to study, and that's going to be different for everyone. I remember I went to HEMA has an exam called Certified Documentation Improvement Practitioner. And when I took the exam, it was actually almost 10 years ago. They didn't have a review guide, like a book where you could look at multiple choice questions. All they had was the outline, like the domains and the tasks. But they had this 2-day review class. And so I went to the 2-day review class, got some good information, but ultimately had to go back home and it might have been one day. Yeah, I'm thinking it might have been one day. But nonetheless, I had to fly there for the review class, but I ultimately had to go home. I had to pull out that content outline and go domain by domain, task by task to pass the exam. All right, on to task number 8. And as promised, we will be doing some principal diagnosis scenarios before the night is over. So it is going to be really cool to be able to get to those because I think that it will help strengthen your skills. All right, so demonstrate knowledge of reimbursement methodologies. So on this content outline, AHIMA talks about DRG and APC. But those of you who are currently coding inpatient, you may say, well, our state has another one that we use, which are APR-DRG, and it's APR is all patient refined DRG, and here in Illinois, they use it for Medicaid claims, like old school Medicaid, not like a HMO Medicaid, but just straight Medicaid. And many other states use it as well. So they didn't specifically call that out here, but I'm calling it out because it is a type of reimbursement methodology. And it is similar to DRGs, but it's different because DRGs take into consideration the risk of like diseases, And APR-DRG looks at death. I might have it backwards in my head. But nonetheless, you can Google APR-DRG, and there are lots of articles out there on it. So, but we will focus on DRG and APC. And so I'm going to start with a review of a website that I have shown you before, but I'm going to show it again. Okay, so these are all websites that you all have been given access to. Whether you have went through them is another question. But I want to kind of bring to life this concept of the APC, grouping a APC, grouping a DRG, which I'm pretty sure we talked about this before, but I want to just make sure. And I'm gonna do APC first because I am I am 90% sure, no, not 90%, 99% sure that we looked at DRG before. So I'm gonna do I am going to do a patient who is in the emergency room. So I'm going to, just to move this along quicker, put in some diagnoses. Uh, just because we just talked about something like this earlier today. So APC is the opposite of DRG. You can have multiple, matter of fact, let me change that word. You can have unlimited APCs on a claim, whereas for the DRG, you can only have one DRG per hospital stay. So with APCs, the grouper product will not assign an APC unless you have a CPT or HCPCS code. So I'm going to put in, I'm going to say that our patient, oh, and I cannot see. 1 second. Here we go with the glasses situation again. I'm going to say that the patient had a CPT of 99283. And so there's a couple of things I want you to pay attention to on this screen. So number one, and really starting, okay, let me get the mouse over. Starting where my mouse is pointing, it says APC, drop to 0, 5023. APC 5023. And then if you go down a little bit, you see status of V. A few minutes ago, I showed you the APC status indicator file. It's addendum D1, and each letter has a specific meaning. So in this particular case, the status indicator that is assigned to APC 5023, which now you know a APC is a 4-character number. The status indicator that is assigned to it is a V, and it's basically telling us that this is a clinic or emergency department visit. So let's say I'm gonna add in some more diagnoses. I'm trying to do diagnoses that I can, not that I've memorized diagnoses, but I'm gonna try to get diagnoses that I can get off the top of my head. All right, so let's say my patient also has severe persistent asthma with status asthmaticus, and I'm going to add in that my patient had a chest x-ray. Uh-uh. Uh-oh. All right. So I want you to notice what happens when I add in my chest x-ray. So I had one APC, and let me just make sure I'm saying this so that it makes sense. Every CPT, the system is going to assign an APC to it. Is going to assign a status indicator. The status indicators are payment status indicators that really tell us how that APC is going to be paid. So watch what happens when I put this chest x-ray in. So now I have, and notice right across from 99283, it says edit 0021, not 0021, OCE. That means I got a outpatient code editor edit. And basically it's telling me I got to put a modifier 25 on that code. So I'm going to add it. And now I have two APCs. I have the original one, 5023, and I have 5521. They're going to pay us for both of these. And again, you see each CPT is assigned a status indicator. I'm going to do one more. Um, all right. So now you see that I've added some additional services. And now I have another status indicator which says N, items and services packaged into APC rates. So inside of Blackboard, and I keep saying this because I want to make sure that you are actually looking at these resources. Inside of Blackboard, in the file that says domain number 1, task 8, APC, I provided you with a list of terms related to APCs, and one of those terms is packaging. And packaging is the practice of bundling certain services together into a single APC payment rather than paying for each service separately. So if you have not taken a look at that, at those files, you definitely want to do so, because I know I said this 2 or 3 times tonight, but I'm going to say it again. You are going to have several practice CCS exams, and now is the time to be looking at the different domains, the tasks, etc. So there's one more example I want to show you, and I'm going to go to another patient. And I don't know why, but every time I do this, I always make everybody 65. Okay. So let me get a diagnosis. Uh, Oh no, I don't want to do that. That's taking me down a rabbit hole that I don't want to go down. So just give me a second. All right. So for now, I'm just gonna type in the diagnoses because I want you to see again, unlike DRG, you gotta put a CPT code in to calculate the APC. For DRG, the diagnoses can drive the actual DRG assignment. All right, so let me get my CPT. So I'm going to say my patient had an appendectomy, and I'm going to say that it's an open situation. I'm going to go continue and notice that I got another OCE edit. Says service considered an inpatient procedure for Medicare patients. And just as a FYI, um, the LID that's behind it is a line item denial. That is a billing term that basically says that particular line item on the claim would be denied. Okay. So now that you've seen APCs, I'm going to do DRG just to make sure in case you forgot. But I am pretty sure we did a DRG. So, let me back up for a second and say something. So, when you saw me using the APC finder, I want you to know that that is a grouper. And what it is doing is grouping together the diagnoses and the CPT code to give me my APCs. The DRG finder that I'm using right now is grouping together the diagnoses and, when it applies, my PCS codes to give me the DRG. When I'm using the APC finder, one of the questions that they asked me was the type of bill, and that is a UB04 claim form terminology. And basically, it's like, is this is this a claim for a single service, multiple services? So, for example, let's say somebody goes to the emergency department. I mean, they go to the lab, to the physical therapy, and they have therapy 3 times a week. And let's say every 30 days you drop a claim. Well, the type of bill can indicate that this is one of those types of claims. All right. So, DRG, instead of it asking me for the type of bill, is asking me what is the disposition of the patient. Now, I don't know if this is still the case, but um, one of the individuals who did an exam prep with me had mentioned that on the exam, they are expecting you to know the discharge disposition. I'm like, what? They're expecting you to know the numbers. So in Blackboard, in the folder 8 under domain 1 that says MS-DRG, I have provided you with the list of discharge disposition numbers. Again, I don't know if they're going to ask you this, but um, again, I want you to be over prepared instead of under prepared. So the discharge disposition is basically, where did the patient go after they left the hospital? Because where they go after the hospital can impact payment. So I'm going to say our patient went home, and my patient who had the appendicitis, I'm going to um, I'm going to code them now as inpatient. All right. So remember, with inpatient, the MS-DRG, you can get the DRG once you put in the principal diagnoses. The admit diagnoses does not factor into the MS-DRG. I want to make sure I remind you of that. K53, I think that was the number. Uh-oh. Oh, Lord. Oh, I gotta come out and come back in. All right, so let me do this real quick. Hopefully I select all the things that I selected before. Oh, shoot. I don't want the procedure yet. I just want to do. Okay, so now I got my diagnoses in, and notice I have a DRG. So just to review, there are close to 800 DRGs. The DRGs are grouped together based on the major diagnostic category. There are 25 MDC categories. Okay, so now I'm going to do my procedure. And because this is a root operation situation, when they did the appendectomy, they took out all of the appendix. So it is going to be a resection. And notice in this encoder, it's even trying to see if I know, is it excision or is it resection? Is it the whole body part? So it's the whole body part. And I'm going to say that this was open. Okay, so now I have my PCS code. I'm going to add it in. And now notice that my DRG changed, my reimbursement changed, the weight of my MS-DRG changed, and now I know I'm 100% sure that we talked about this before. So I also want you to notice that this situation says without CC, MCC. And on the CCS exam, I want to say this again, that you maybe asked a question about CCs and MCCs. All right, enough of that playing around in that encoder business. And let's go back to this task, which is task number 8, and get into some questions. So this first question, when a Medicare patient is admitted to the hospital as an inpatient, we will be paid under the inpatient prospective payment system and will use a grouper to determine so what will we determine? The MS-DRG. That is correct. The MS-DRG. All right, here's another question. When a Medicare patient is seen in an ambulatory clinic at a hospital as an outpatient, we will be paid under the outpatient prospective payment system and will use a grouper to determine the and it's going to be the APC. So the opposite of DRG is the APC. All right, so the next question. Ha! Under the APC reimbursement methodology, each CPT HCPCS Level 2 is assigned a blank as a payment indicator to identify how each code is paid or not paid under OPPS. And I just talked about this. I feel like I talked about it again before, but you know, More than once always helps. And nobody is looking at this, knows this answer. And so I'm going to tell you, in the interest of time, and it is A. I can't believe you guys don't know this answer because I literally just talked about it, but it is a payment status indicator. Remember, when you solve when I was just in 3M, so each APC, each CPT HCPCS had a payment status indicator. All right, next. Medicare considers some procedures inpatient only, meaning they do not reimburse for these procedures if they are performed in an outpatient setting. What payment status indicator is used in OPPS to identify an inpatient only procedure? And I literally just showed this to you on the screen. Just to see if you are paying attention. LID is line item denial. Here, we're looking for that payment status indicator. And this is a great time for you to go into Blackboard and go to the APC folder and click on the Addendum D1 status indicators if you don't know the answer. And that is correct. It is the letter C. All right, next question. When a patient signs out of the facility to go home without a discharge order, what discharge disposition will be assigned? And if you don't know, you can go to Blackboard, go to the APC folder, and click on the patient discharge status code reporting. Discharge status, discharge disposition is the 2-digit code that identifies where the patient is at the conclusion. So what is the discharge disposition for the situation where the patient says, I'm out of here. I'm out of here. I'm done. And it is, and let me just reiterate this, the discharge status, aka the discharge disposition, is a 2-digit code, and it is a 07. It is a 07. So on the exam, if they ask you for the discharge disposition code, AMA is not going to be an option. You will need to provide the actual code. Again, let me just say this. I have had people say on the exam that they needed to know these numbers. My person who just took the exam the other day, when I asked him, he didn't remember. And one of the things I will say, a lot of times people remember like the questions that they had a lot of them. When they have the one-off questions, they don't typically remember. But again, you've been provided with these resources for a reason. What you do with them is up to you. All right, so we've been at this for an hour and 20 minutes. So I think that we definitely need to take a break. So um, let's do a 15-minute break. And I'm gonna get the timer on right now. I would encourage you to make sure that you download all the files, etc., that were provided to you, because the practice CCS exam will be here before you know it. And you don't want it to be something that you start looking at the day before, because you might not know when the day will be. Oh, that's 15 minutes and 3 seconds. All right, we are back. We are still looking at domain number 1. And in case you are wondering, next week we will continue with the domains, because I want to make sure that you see that everything we've been doing is really tied to these areas that you need to know for the CCS exam. All right, so we did task number 8. So let's go on to task number 9. So, oh, my voice is really scratchy tonight. So, domain number 1, task 9, abstract applicable data from the health record. So, when I look at this sentence, what it says to me is that examinees should be familiar with the contents of an inpatient record, an outpatient record, and then should be able to pull out information when asked. I honestly don't know what AHIMA's formal, I'm sorry, my throat is very scratchy today. I don't know what AHIMA's official position on this is, but I just think you need to be able to pull stuff out of the record that when it applies. So just a couple of questions, and really these are going to be some screens that I'm going to show you. And this is, again, just abstracting information out of the record. So for this particular patient here, a simple question: how old is the patient? And you are correct. The patient is 79 years old. All right. The next question for a different patient is this patient a smoker? And you are correct. The answer is no. For this next patient, who is the patient's doctor? And it is Dr. Brenton. The next screen, and again, I don't know what type of questions that AHIMA has on the exam related to this area, but I think I don't know if they're going to show you actual records. Next question is the heart murmur acute or chronic? It is chronic. And then the last patient, what is their medical record number? This is probably the easiest one we've done. And it's the MR5 2000. All right. And the last task, identify major comorbid conditions and comorbid conditions. So for this activity, you are going to need a file that is in, you're going to need a file that is inside of Blackboard. And I just noticed that one of the files, MS-DRG versus APR-DRG, is not working. But anyway, the file that you will need, or the, what do you call it? You will need, and let me just actually put it on the screen and in the chat, just so we can make sure everybody has it. And give me a second, because I don't know if some things have been moved around. So, so this is the page. It's the, I showed this earlier. It's the, and it's available for you in Blackboard. This is the Medicare payment, prospective payment system, acute inpatient PPS. And then you're going to go to MS-DRG classification and software on the left. And then from there, we are looking for the MS-DRG definitions. And so the definitions manual. So you got to scroll down and you're going to go to number 3, proposed ICD-10 CM MS-DRG version 43 manual, table of contents, full title. So this is where we're going to be for a second. And so again, how I got here, just for clarity, we were on the page that says Medicare payment, prospective payment system, acute PPS. On the left-hand side, we went to MS-DRG classification and software. Once we got there, we scrolled down, looking for the MS-DRG definitions manual, and it was number 3, the one here that says full titles HTML. So for this next domain task, the final task, identify major comorbid conditions and comorbid conditions. So one thing that I had, that I've said a couple of times, I want to make sure that I continue to say it, on the day of the CCS exam, you need to have the hospital version of the coding manual, and today is going to really solidify the why. So, but what we're going to use in the meantime, and actually we're supposed to be looking at version 42, but this one is fine. So what you're looking at is Appendix G, diagnoses defined as complicational comorbidities, and Appendix H, diagnoses defined as MCCs. So what I would recommend you do is right-click on each one so that you can have each tab open. so that you can search for what you're looking for. And again, you were provided with this page before. So if you have not taken a look at it, shame on you, because this is too much stuff to do once we are all done. All right, so now we're going to go into the questions, and I'm going to walk you through how you would approach these questions. All right, so a patient is admitted with shortness of breath and an acute exacerbation of COPD is diagnosed. The patient also has stage 5 hypertensive kidney disease, hypokalemia, and hyperlipidemia. Which code is a CC for this scenario? So the first thing that you need to do in this scenario is identify which condition is the principal diagnosis. And you need to do that so that you can take that diagnosis out of the equation. Why? The question about if it's the CC or the MCC is related to the secondary diagnoses. So, based on this scenario, what is the principal diagnosis? And again, principal diagnoses, condition established after study to be chiefly responsible for the admission. So what is the principal? And you don't have to give me the code number, just give me the word. Okay. So yes, it is the acute exacerbation of the COPD. So now you put that to the side, and then you take your secondary diagnoses. And if you had the physical manual hospital version, you would just look up the numbers to see which one of them is a CC or an MCC. So, for purposes of making sure that we don't run out of time, I will give you the code numbers. So, hypertensive CKD is I12 0. We don't know the stage. So, oh, we do stage 5. So then you would put the N18 code. And then the patient also has hypokalemia, hyperlipidemia. So those are E78.5, E87.6. And so the next thing that you would have to do if you had the code book, you literally could just look in the tabular and see which one of them has the symbol next to it. But in this case, since you don't have that, what you literally would have to do is, and I started with CC, you literally have to look at the numbers that you have. So we had E78 and E87. So you look for the numbers in here. And E78.5 is not listed as, and let me just be clear. This question was asking which code is CC. So basically, we're looking up each of them. So E78.5, I don't see it on here. So now I'm going to go to E87.6. That's not on here. And I am going to, now I went in numerical order. I'm going to go to I-12. And I-12.0 is on here. So on the day of the exam, when they ask you which diagnoses is the CC, first, you figure out what is your principal. You put that to the side, and then you look at your secondary to see which one of those is, in this particular case, is a CC. Did everybody understand what I just did? And we have 4 more questions, so we will get to practice this again. Again, hopefully you see why you need the hospital version of the manual, because you're not going to have access to this file. So is that a yes, no, maybe? Okay. So the list that I gave you, so let me go, let me go back to this screen. So what we did for purposes of us being able to have it available, we right-clicked on the MCC list and got it open. We right-clicked on the CC list, but for this particular question, they were asking about the CC. So all I did was stay focused on the CC list. That makes sense? Because it didn't ask, that question didn't ask me about an MCC. Okay. I think I must have too many windows open because my computer keeps giving me a funky message. All right, let's go on to the next question. An inpatient with cirrhosis is treated for esophageal varices with hemorrhage, uncontrolled hypertension, hypothyroidism were treated during this admission as well. So which of the secondary diagnoses would be the MCC? So now this time you're not looking at the you're not looking at the CC, you're trying to figure out what is the MCC. I don't know what's going on with my voice. So again, just to make this faster, I'll give you the codes. So you know hypertension is I10, hypothyroidism is E03.9. Oh, I forgot to ask you, what's the principal diagnoses? I forgot that part because that's the first step. You have to identify what your principal is and take that out of the picture. The very first step, because it's the secondary diagnoses that is going to be the CC or MCC. And in this particular case, they're asking for the MCC. So which one is the principal diagnoses? Okay. So the esophageal varices with bleeding. So I gave you the code for hypertension. I gave you the code for hypothyroidism. I don't even remember what the code is for cirrhosis. I think it's K74 something. Maybe like, let's just use K7460. That sounds good. So it's the secondary diagnoses that you need to look up to see which one is an MCC. So just to make sure everybody is on the same page, from that page, you're going to go to Appendix H because that's the page for the MCC. And you're going to look up those 3 diagnoses to see which one of them is an MCC. Cirrhosis is an MCC. All right. All right, let's go to the next one. A patient is admitted to an acute care facility for detox, secondary to chronic alcoholism and barbiturate abuse. The patient also has cirrhosis of the liver due to alcoholism. The stay is complicated by alcohol withdrawal and metabolic encephalopathy. What condition is an MCC for the scenario? And so again, the first thing you got to do is identify what is the principal diagnosis. And as a reminder, after we finish task 10, we will do some questions on identifying the principal diagnoses just to get some more practice. So what is the principal for this patient? So the principal, as a reminder, is a diagnosis. So the principal is not the procedure. So what is the principal diagnosis? Is the alcoholism, right? It's the alcoholism and the barbiturate. Okay. So then you pull those to the side and you got cirrhosis, you have metabolic encephalopathy, and I don't know why I don't have the code for metabolic encephalopathy. It starts with an E, I think. Oh no, it's a G9341. G9341. And that is an MCC. Yeah. Okay, let's do the next one. And wait 1 second because I got too many windows open over here. All right. Patient is discharged. So one of the things I like about doing these scenarios is that you get to actually see what your thought process would be on the day of the test with the physical manual. A patient, and I don't know if they will give you the question and it'll have codes. They give you questions and it'll be the words, but at the end of the day, you still have to go look the numbers up to see which one is which. All right, patient discharged with hemiplegia, cephalopathy associated with a cerebral infarct, left side of the brain due to cerebral artery stenosis. Patient is right-handed with a history of hypertension, compensated congestive heart failure, both conditions currently controlled on medication and treated. The question is, what is the CC? And one of the things I will tell you, there are some diagnoses that you just will learn are not CCs or MCCs. So, for example, just plain old hypertension is not a CC. And so, of course, the first question you got to ask yourself is, what is the principle? The infarction. Okay, so then now you have to ask yourself, what is the CC? And hopefully everybody knows I-10 is the diagnosis for hypertension. Compensated CHF is I-50.9. The patient also has cerebral artery stenosis. So I see an answer. I want to make sure that everybody agrees. And somehow my screen closed. So I don't see, wait a minute, let me go back up because I'm on the wrong file. 1 second, let me go back to my CC file. So I don't see that I-50.9 is a CC. Just plain old congestive heart failure. And let me bring my window into the screen. So I don't see that as a CC. It has to be systolic, congestive. It has to be one of these, but the plain old I-50.9 isn't there. I-10 is also not a CC. So let me bring the scenario back over. I don't know if you guys are seeing this here, but I'm going to just pull this up here. Hello, are you guys still there? Okay, so does everybody understand what you're doing? So you got to look up all the secondary diagnoses. And so I found hemiplegia on there as a CC. And earlier we said encephalopathy was one as well. So, okay, let's keep going because I don't want to run out of time. Here's the last one. A patient is admitted with CVA with resulting left hemiplegia. They have atrial fibrillation. They have type 1 diabetes. Which of the diagnoses will trigger a CC based on the sequencing? So here they're calling out, first you got to know what is the principal. And we know that it would be the CVA. And then the secondary diagnoses would be hemiplegia, the atrial fibrillation, and the diabetes. So of those three, hemiplegia, atrial fibrillation, and diabetes type 1, what would be the CC? And not the number, just the words. The hemiplegia again. All right. So let's take just a 5-minute break. I need to switch screens for the principal diagnoses. So let's take a 5-minute break so that I can transition over to that screen. Oh, not 50 minutes. And then that will be all that we will do. All right, we are going to resume. This is the last thing that we're doing today. There are 28 scenarios, if you will. Um, I won't read the question. I'll just put it up on the screen, and then you can identify what is the principal diagnosis. So we're not looking for any secondary, just the principal, unless it tells you about a secondary. And you don't need the code, just the words. What is the principal? And it is congestive heart failure. And I want to remind you that right now we're just talking about the principal, but just remind yourself that um, as you would consider the secondary diagnoses, signs and symptoms integral to a disease process would not be coded separately. All right, here is the next question. And there is a guideline that applies for this scenario. And that guideline is about when the original treatment plan isn't carried out. The original treatment plan isn't carried out. What does that guideline say? And I know for sure we saw that guideline before. So I'll just read this guideline real quick. When the original treatment plan isn't carried out, the condition that led to the need for the admission remains the principal diagnosis, even if the treatment was not provided due to unforeseen circumstances. So the principal would be BPH. Does everybody understand that guideline? The original, so if you have not read these guidelines and you read them and you're not applying them, then you need to go back and read them again. All right, next patient. And I'm just going to be honest, I tried to trick you to see if you would notice that the last situation and this situation is exactly the same. The original treatment plan was not carried out, but you still code the reason they were there, which was the osteoarthritis of the knee. And don't allow a test to trick you. A total knee replacement is not a diagnosis. And I've seen that type of question before where they try to trick you and they're asking for the diagnosis, but then they list total knee replacement as one of the options, and that's not a diagnosis. So it would be the osteoarthritis. Now, just for clarity purposes, if you were coding this, you would have additional diagnoses for the hypertensive heart disease, all that stuff. Okay. You would still code that. You would code it as a secondary. All right, next. So it shouldn't take you guys that long to figure out what the principle is. This is a simple question for each scenario. And it would be the status asthmaticus. And status asthmaticus basically means that the patient's asthma is not controlled with medication that they've been getting. And so they got to be admitted and get that real medicine in the vein. All right, next patient. So I want to call out here that both of these conditions required IV medications. It wasn't one was IV and one was by mouth. So there is a guideline that says when two diagnoses equally meet the definition of principal, either could be sequenced as principal. All right, next. And same situation, just worded a little differently. So, yes, either one can be sequenced, they equally meet. So one of the things I want to call out here that you may be thinking about is, well, how is respiratory failure treated? How is COPD treated? And they basically would be doing the same type of treatment for both of these conditions. They're both respiratory conditions and would be treated, in this particular case, they would get the same regimen: antibiotics, steroids, pulse ox, all of that. So, what is your answer? So, since these would be treated equally, either could be sequenced as principal. So, the respiratory failure, the COPD, they would get the same stuff: IV antibiotics, steroids, oxygen. So, either could be principal. Also, for those of you who currently code at inpatient at work, let me call out something that is important for you to know on this exam. At work, you might be instructed, whichever one costs us more to treat, that's the one you're going to sequence as principal. On this test, you got to follow the guidelines, and you would not have any type of system to tell you which one is going to be more versus the other. All right, next. Ooh, this was a good one. And it would be aspiration pneumonia, because in the inpatient setting, uh probable, I think it is, it could be, it might be, it looks like it's coded as though it exists, unless a chapter specific guideline says otherwise. Next scenario. Wound dehiscence is correct. There is a guideline that says something like complications of surgery and other medical care. You list that complication as principal. Next. And that is correct. Either one could be principal. What I want you to notice here, they're both treated with IV antibiotics. So that, tells you that it's an equal situation versus one being treated, with PO medications. All right, next patient. And the aspiration pneumonia is principal. The guidelines call out that if you look at outpatient, anyway, consistent with is one of those uncertain diagnoses, um, but it is coded as though it exists. Viral gastroenteritis is correct. And we know we would not code fever, abdominal pain, nausea, vomiting, diarrhea, because those are symptoms. All right, either because they are interrelated conditions, meaning they're from the same ICD-10 CM chapter, both were treated during the hospital stay, so either could be. Iatrogenic pneumothorax is correct. Next. Watch out for this one. Watch out for this one. Principal diagnosis is about inpatient care. Observation is not an inpatient service. So it would be the PE, the pulmonary embolism. The more of these you guys are doing, I feel like you're rocking and rolling over here. It can be either or. Either or it could be principal. All right, next. All right, orthostatic hypotension is correct. So, COPD, back pain, both received treatment, both left home, left with something, they equally meet the definition of principal. They equally meet the definition. They both were treated equally. All right, next. All right, either could be principal. Next. All right. So in the scenario, the doctor said the patient did not have epilepsy. So the principal diagnosis is going to be seizure because he ruled out the epilepsy. They didn't have it. Next. And it is the viral pneumonia. Next. All right. Remember that guideline from earlier when the original treatment plan is not carried out? That condition is still principal. So you could code that other stuff, but the question is, what is principal? The original treatment plan was not carried out. Keyword here, original plan. Next. All right, either. Next. Post-op bleeding. This is a complication from the surgery. Post-op bleeding. Next. Wound infection is correct. Next. I've been talking this up all night, and here it is. The gastroenteritis was treated with PO medications, which means you pop a pill in your mouth. Dehydration is IV. So we would code the the dehydration as principal. And I think there is a coding clinic on this somewhere. I'll have to see if I can find it. Not today. All right, next. I wonder, do they even still have that medication? Oh, they still got it. I thought that medication was black boxed or something. All right, UTI. And whoa, we made it to the end. I